Massive GI bleed in HIV AIDS, an atypical presentation of gastric Kaposi sarcoma. Abstract. Kaposi sarcoma is the most common gastrointestinal visceral malignancy in HIV seropositive patients. We report a case of massive gastrointestinal bleeding as the initial presentation of gastric Kaposi sarcoma in an HIV patient who self-neglected. Introduction. There is a well-established relationship between a diagnosis of HIV and depression among patients with prevalence between 22 and 45%, which is due in part to the social stigma surrounding these conditions. The compounding of depression and HIV may in turn lead to poorer outcomes. These poorer HIV outcomes are dependent upon a number of factors, some of which include adherence to ART regimens. In AIDS patients, the CD4 count appears to be one of the best both prognostic and predictive factors for the development of KS. Lodi et al. Describes in their study that the rate ratio of KS development in patients on ARTs was 18.9 between patients with a CD4 of less than 200 compared to those with a CD4 of greater than 500. More widespread use of ARTs in the past decades have decreased the standardized incidence ratio of KS from 22,100 to 3,640. Classically, KS presents as numerous polymorphic cutaneous lesions. However, cases of visceral KS have also been observed, especially in the oral cavity, gastrointestinal tract, and respiratory system, and rarely in the liver, testes, heart, and bone marrow, albeit less frequently since ART has gained more widespread usage. In the absence of early and regular ART, rates of concomitant gastrointestinal KS is as high as 40% on initial presentation, usually with nonspecific gastrointestinal symptoms, most commonly abdominal pain, and 80% on autopsy. Case report. A 53-year-old male with past medical history of HIV AIDS, depression, and anxiety, non-compliant with ART, presented to our center with worsening right leg pain and chronic, tender, non-healing ulcers on the bilateral lower extremities. At presentation, the patient was anxious and extremely cachectic. The skin on his lower extremities revealed multiple purplish lesions with no crepitus. He was afebrile to 36.9 degrees Celsius, and the remainder of his vital signs were significant for hypotension at 85/56 and tachypnea. Ultrasound duplex and CT scan of the lower extremities were negative for venous thrombosis or arterial stenosis in the lower extremities. Medical management was the most reasonable course of action, including IV fluids and antibiotic prophylaxis for opportunistic infections, given that his most recently documented CD4 count from 3 months prior was less than 50. Hemoglobin on admission was 12.3. A subsequent CBC revealed a drop of hemoglobin to 6.6. The patient adamantly refused blood products. A nuclear medicine gastrointestinal bleeding scan was ordered, which was negative for active GI bleed. The patient refused a digital rectal exam for fecal occult blood. Overnight, the patient had a massive GI bleed with bright red blood per rectum and was emergently given 3 units of PRBCs. An emergent EGD was performed. Colonoscopy was held until bowel preparation was possible the following day. The EGD revealed multiple small and large infiltrative non-circumferential masses suspicious for Kaposi sarcoma without active bleeding. Stigmata of recent bleeding were found around the gastric fundus, in the gastric body, and in the greater curvature of the stomach. Biopsies were taken for histology. The duodenum and rest of the exam were normal. Biopsy results returned the next day to reveal gastric Kaposi sarcoma. The patient had multiple comorbid conditions that put him at risk of rapid decompensation, including cachexia refusing nutritional rehabilitation, AIDS refusing ART, anxiety, and depression. The patient was placed on aripiprazole 2 mg oral daily and was discharged to hospice care with psychiatric support. Discussion. Contrary to popular belief, the most common gastrointestinal visceral malignancy in HIV seropositive patients is Kaposi sarcoma. Given that gastric KS typically presents with nonspecific gastrointestinal symptoms, with definitive identification and diagnosis being made via endoscopy and biopsy, our patient's massive GI bleed, in the reported absence of abdominal pain, represents an atypical initial presentation for visceral KS. We present a patient who was previously compliant with ART and upon experiencing a relapse of depression and anxiety, lost motivation to continue treatment. This lack of motivation also bled into other aspects of his life, including isolation from his primary social support, his brother, and deterioration into both unstable and inadequate housing in his car. The advent of ART has significantly decreased the mortality of patients with HIV-associated conditions, such as AIDS-associated KS, so restarting this patient on ART and helping him develop a more robust social support may have slowed the progression of his symptoms. This case demonstrates the need for more robust neuropsychiatric support for HIV seropositive patients, most of which should come from the primary care team in terms of early recognition. The onus also falls on the primary care team, namely the physician, to stress the importance of adherence to ART. This multifaceted approach to care aims to decrease the incidence of severe and often rare complications of this disease. We also hope to highlight gastric Kaposi sarcoma as a potential cause of gastrointestinal bleeding in HIV AIDS.